Welcome back. Let's dive right into today's explainer, where we're tackling a fascinating yet intensely challenging condition, hemiplegia. Imagine your life altering in a split second, your brain suddenly unable to communicate with half of your body. That's exactly what we're unpacking today, the hard science, the complex anatomy, and the day-to-day reality of this diagnosis.
First things first, what exactly are we talking about here? Essentially, hemiplegia is the complete loss of voluntary movement on just one half of the body. We're talking an arm, a leg, and very often the facial muscles on that exact same side. You know, this isn't just your standard muscle weakness, it's a profound paralysis. And it happens because the specific motor pathways in the brain or spinal cord, the ones that literally command us to move, have been severely damaged.
To give you a quick roadmap of our explainer today, we're going to map out the anatomy and demographics, dig into the origins and mechanics, and then walk through the symptoms, mimics, diagnosis, and management before finally wrapping up with prognosis and prevention.
All right, let's jump straight into Section 1, Anatomy and Demographics, where we'll be mapping the mind and body.
To really grasp what's going wrong here, you have to think of your nervous system as your body's internal electrical wiring. Your motor signals actually start up in the frontal lobe, right in an area called the primary motor cortex. From there, these signals travel down a highly specific superhighway known as the corticospinal tract. They zip through the internal capsule, plunge down the brainstem, and finally enter the spinal cord to meet the peripheral motor neurons. When this wiring works perfectly, you can effortlessly walk, grab your coffee, or smile. Hemiplegia happens when this exact, delicate pathway gets disrupted.
So, who's most at risk when this system fails? Well, while it can happen at absolutely any age due to trauma, an infection, or maybe a tumor, stroke is the undisputed primary driver here. In fact, stroke is literally the leading cause of adult hemiplegia worldwide. Naturally, the risk goes up as we age, and it remains a massive driver of long-term disability globally, especially in places like Nigeria, where the clinical burden of stroke is just incredibly high.
Moving right along to Section 2, Origins and Mechanics. Let's look at the causes, risks, and pathophysiology.
What's actually severing these wires? Cerebral vascular diseases definitely lead the pack. We've got ischemic stroke, which is essentially a blockage of the cerebral arteries, and intracerebral hemorrhage, which destroys surrounding brain tissue through active bleeding and compression. But hey, it's not just strokes. Severe head trauma, space-occupying brain tumors, or intense central nervous system infections, like meningitis or brain abscesses, can also compress or completely sever these vital motor pathways.
Now let's talk risk factors, because these are what essentially set the stage for that structural damage. We're looking at conditions like hypertension, diabetes, hyperlipidemia, obesity, smoking, and cardiac diseases, with atrial fibrillation being a major player. These aren't just background noise. They are directly responsible for creating the hostile environment where an ischemic or hemorrhagic stroke is much more likely to strike.
Okay, this part is actually really fascinating. The body has this ultimate cross-wiring setup down in the lower brainstem, specifically at the medullary pyramidal decussation. This is the exact spot where most of those corticospinal fibers we talked about actually cross over to the opposite side of the body. Because of this little architectural quirk, if a lesion happens above this crossing point, the patient gets contralateral paralysis, meaning the opposite side of the body goes down. But if the lesion happens below this point, say in the cervical spinal cord, it causes ipsilateral paralysis, so the exact same side as the injury is affected. Makes sense, right?
That brings us to Section 3, Symptoms and Mimics, covering clinical presentation and differentials.
When a patient presents with hemiplegia, we're seeing a lot more than just a weak arm and leg. Because the damage hits the upper motor neurons, it throws off some very characteristic neurological red flags. We're talking about spasticity, which is an intensely increased muscle tone. We see hyperreflexia, a positive Babinski sign, where that big toe flexes upwards when you stroke the sole of the foot, and clonus, which are those involuntary rhythmic muscle jerks. Plus, depending on where exactly the brain took the hit, this motor loss often travels with things like aphasia, visual field defects, sensory loss, or even serious cognitive impairment.
But wait, establishing a differential diagnosis is absolutely crucial here because we have to rule out the mimics. Not every sudden unilateral weakness is a permanent stroke. There are several other metabolic or neurological disorders that can totally masquerade as hemiplegia. A transient ischemic attack, multiple sclerosis, an undiagnosed brain tumor, a slow-bleeding subdural hematoma, or honestly, even severe hypoglycemia can look exactly like hemiplegia when that patient first rolls through the ER doors.
So how do we figure out what's really going on? let's get into Section 4, Investigations and Diagnosis, where we're uncovering the damage.
In an acute setting, remember the golden rule: time is brain. A CT scan is our rapid response tool and absolutely the first-line imaging study we order. Why? Because it can instantly visualize life-threatening bleeding or massive tissue damage. If a patient's having an intracerebral hemorrhage, that CT scan is going to show it immediately, and that completely alters our treatment playbook on the spot. Now, once that immediate emergency is assessed and stabilized, we sequentially follow up with an MRI. An MRI is going to give us highly detailed, nuanced imaging of those brain structures. It's fantastic for catching the very small infarcts or tumors that a rapid CT might just miss. And of course, alongside this imaging, we're running full laboratory blood panels, checking glucose, lipids, coagulation, and doing cardiovascular evaluations like an ECG to hunt down the true root cause, like a rogue cardiac embolus.
Next up is Section 5, Management and Complications, or as I like to call it, the road to recovery.
When we talk about acute management, the immediate goal is pure survival and damage control. If the hemiplegia is from an ischemic stroke and the patient gets to us within a very specific narrow therapeutic window, we can actually administer thrombolytic therapy to bust that clot and restore blood flow. But if it's a hemorrhagic stroke, our focus aggressively pivots to blood pressure control and getting neurosurgery involved if needed. And throughout all of this chaos, maintaining the patient's airway, breathing, and basic nutritional support is absolutely non-negotiable.
That acute, life-saving intervention naturally hands the baton over to long-term care. And let me tell you, long-term recovery is not just about popping pills. It completely relies on a holistic, multidisciplinary rehab team. You have physiotherapy to help restore movement, occupational therapy to rebuild those essential daily living skills, speech therapy to tackle aphasia or swallowing issues, and crucially, psychological support. Because, honestly, the mental toll of waking up and suddenly lacking control of half your body, it's immeasurable.
Without that aggressive early mobilization and team-based care, patients are basically sitting ducks for some severe, cascading complications. We're talking permanent muscle contractures, excruciating pressure ulcers from being immobile, deep vein thrombosis, life-threatening pneumonia from aspirating food, and deep, profound depression. Let's be clear, preventing these complications is arguably just as critical as treating the initial brain injury itself.
Finally, let's wrap things up with Section 6, Prognosis and Prevention, looking ahead.
So what does the future look like for these patients? Well, prognosis heavily depends on the root cause, the extent of the damage, and just how fast they received medical intervention. While some folks will unfortunately face permanent neurological deficits, there is still immense hope. The human brain has this incredible ability to essentially rewire itself. We call it neuroplasticity. Because of this, partial recovery of motor function actually happens quite often, usually during a critical 6-month window post-injury, assuming the patient is putting in the work with rigorous rehabilitation.
All of this leaves us with one very vital question. Knowing the absolute devastation hemiplegia causes to both the mind and the body, how do we stop it from happening in the very first place?
The answer is actually pretty straightforward, even if it's not always easy. Prevention completely relies on mitigating those exact risk factors we highlighted earlier through aggressive, everyday lifestyle modifications. It means keeping a tight leash on hypertension, managing diabetes, quitting smoking cold turkey, actually committing to regular physical activity, and eating a healthy diet. At the end of the day, it's about protecting the blood vessels that feed the critical motor pathways in your brain. Ultimately, the fight against hemiplegia isn't just an individual battle. It really is a community effort. Public health programs focused on reducing cardiovascular risk are absolutely essential here. They serve as a powerful reminder that protecting our cardiovascular health is the single best way to protect our brain.